Hey, I'm Olivia McKinley, and I'm going to talk to you today about the head tilt and/or head rotation maneuver for swallowing and dysphagia. So with these two methods, they kind of go in together, but at the same time, they're a little bit different in the way that you need to think about performing them. So a head tilt is kind of focused more on the oral prep stage, while head rotation is going to be focused more on the oral pharyngeal stage of the swallow. With head tilt, it's focused more on the mastication of food. So if I had Sarah here, who had, let's say her left side is weak, because both of these maneuvers, the candidates for them are usually individuals who have a unilateral deficit, which means occurring on one side of their body. So if Sarah has a left side deficit, and on head tilt, I needed her to chew her food, I would ask Sarah to tilt her head towards the strong side of her body. So if this is the weak side of your body, Sarah, and I gave you food, you would need to tilt your head to your strong side on the right, actually. Okay. So if I was to give Sarah food and I said tilt your head to chew, she would turn it towards that strong side so that gravity could help bring the food to that side of the mouth and allow for adequate mastication. Head rotation, however, is a little bit different. If you were to give the patient any food or liquid, they would need to turn their head toward the weak side, actually. This is because when we swallow, we have our pharyngeal esophageal segment and the upper esophageal sphincter, both of which remain contracted when relaxed, but when we swallow, they relax some and then they allow the bolus to pass through. So if I was to give Sarah a sip of water, I would want her to turn her head toward her weak side, so this way, and allow for a swallow. So this would mean that it would close off the weak side, which would keep the pressure change adequate on the strong side, and allow for a longer bolus manipulation and pull down on that strong side. The good thing about this is that it does kind of require very little technique. However, Grower, our book, does say that things to think about with this strategy are that it is not a lifelong strategy. It's more of a temporary compensatory strategy for that weak side. And also that there's different factors to think about with this head tilt and or rotation, because you need to think about your patient's cognitive ability as well as their if they're able to move. So when doing my research, I found more research on head rotation than I did head tilt. And with head rotation, I found a lot of times in research they would pair it with a chin tuck. So a chin tuck, Sarah, would be if you turn your head to the weak side and tucked your chin slightly. That would allow for greater closure on that weak side and closing of the airway, and allow for that strong side to still manipulate and carry down the liquid or bolus. So the first article that I found was actually by an author named Ballou, and they actually confirmed that they thought that head rotation would move the bolus to the direction opposite of the so if you turn your head to the weak side, it would move it to the opposite direction, the strong side. So they actually paired this with a chin tuck, and they took 10 participants, all who did have healthy swallowing, and they used inclinometers to measure the degree of head tilt, and they wanted to see if either a partial head tilt, a head rotation, or a full head rotation would still close off the upper esophageal sphincter and the PES and allow for the bolus to still pass through without residue. So they used thin liquid in their trial, and they actually found that both partial and complete head rotations had no clear benefit for changes in the vallecula and piriform sinuses, but they did note a duration of the pharyngeal contraction being decreased, which means that it relaxed for a longer amount of time for the bolus to pass through. So that being said, that was in 2014, and the next article that I found actually was in 2016, and they actually kind of built off of this article in 2014's literature and expanded a little. So this next one was by author's last name is Ahmed and colleagues, and they wanted to focus on how to decrease the amount of residue that was in the vallecula in a swallow. So they actually took 73 participants and then narrowed it down to 26, and those 26 had consistent vallecular residue left over after the swallow and had different variations of the primary diagnosis, such as brain injury or stroke. So they gave them different variations of thin liquid, honey, and spoon-thick barium, as well as nectar. And they used solids like minced vegetables and bread and cookies. So they found significant reductions in post-swallow measures of follicular residue when used with a head rotation and a tuck. This particular maneuver showed the greatest effectiveness actually too with thin liquid and nectar thick liquid rather than with just solid food. So they think that this means that the thin liquid is flowing more easily out of the vallecula because of that head rotation and the chin tuck. It's able to allow for a wider opening for that to go through in the esophagus, as well as that squeezing of the chin tuck does keep the liquid from pooling in the vallecula. So, thank you, Sarah, for helping participate, and that is head tilt and or head rotation.